Last thing I want to just say is, um, well, I'll get into that later, but really, if you have any questions about the product, let us know. Reach out to support at Platinum Biologics, anything that's referenced tonight. We do have welcome packages as well that we can give you. You could say, hey, I'd like my welcome package or clinic package. With that, I will shut up and get out of the way. But lastly, I'll say, I'm Beeben Russell. It's nice to meet all of you. For those that have been continuing, thank you for showing up to our events and bringing your friends. Dr. Martin, go ahead and take it away.
So I'm Dr. Scott Martin.
Lastly, sorry, Dr. Martin. Sorry, I killed it. I know. Last thing I'll say. This is our biologics below the knee, specifically for podiatrists. And I just want to say, from a company standpoint, I want to point something out here. Before we talk pain, before we go into these other segments, there's a reason why me and my company and all of the people at Platinum are focusing on podiatrists, because we think there's the largest opportunity with biologics below the knee and podiatrists. So I just want that recognition of that. And for the podiatrists that, this may seem new to, it's not new. This is happening out there, but I think this is going to be the biggest thing in podiatry coming forward. So with that, thanks, guys. Take it away, gentlemen.
Eben, my humble thanks and appreciation for the opportunity to do this. For all of you that don't know, I'm Dr. Scott Martin. I'm an interventional pain doctor by training. I've been in practice for about 25 years. Beeben and I have known each other for a little over 4.5 years. I actually left practice in the state of Southern Nevada and moved to work with him. I was so struck by how bright he was and how forward-thinking he was. And really, I can't express enough gratitude for what he's built with Platinum and allowing me as a provider to completely change how I practice medicine and how I apply medicine to be able to really get some of the best outcomes I've ever gotten in 25 years of practice. Dr. Bell, please do introduce yourself. Certainly, I'm a needle jockey. I'm just a pain guy, but Dr. Bell, he's a surgeon.
Good afternoon or good evening, and Dr. Martin is being awfully humble. I've learned a heck of a lot from Dr. Martin over the last probably close to at least a year or so at this point. So I think intuitively, I always knew the body had an incredible ability to help treat itself. And a quick bit of my background as a surgeon, a little anecdote. I operated at a large hospital, and we need to be credentialed for the procedures that we do. And way back, probably about 20 years ago, I went through hell advocating for microfracture surgery. And for all the podiatrists out there, a lot of you can relate to this. I would see so many stress fractures in my practice in the metatarsal bones. And I'm just using this as a small example and it gets into biologics, because biologics are a great way for the body to help supplement itself. The body is very capable of treating itself if you give it the right ammunition. And that's what we're doing. So I went through hell being credentialed to do microfracture surgery. And it just made sense to me as a young surgeon, if I have a stress fracture in a bone, in a metatarsal bone most often, that's been symptomatic for 6 months, and I've offloaded them. And I've done everything you can do for traditional care for a fracture, and it hasn't worked. And they're 6 months into symptoms, or they're referred to me by the orthopedic surgeon who denied there was a fracture sometimes, or didn't see it because it was not positive on x-ray. But I did an MRI because they have chronic pinpoint pain upon palpation at the second metatarsal head, and it lights up on MRI, and it's clearly a stress fracture. The marrow lights up on MRI, and they're 6 months symptomatic. It's done. There's nothing going on there. And I advocated for microfracture surgery. And I went through hell getting it approved to be credentialed to do it. So finally I was credentialed, and I started doing microfracture surgery for chronic stress reactions with fantastic results. And that's what ultimately led me to looking into and using PRP. And beyond PRP, I was still looking for something better. And that's what led me to allogenic mesenchymal stem cells and to this company, to Platinum, to Beeben, and to Dr. Martin. So that's kind of been my evolution. I've always known it, and I'm just trying to get better and better at it. And working with this company and with these guys and their support, it's not only helped my practice immensely, but I think it's helped me help a lot of my fellow podiatrist practices around the country. And that's been pretty cool.
Absolutely fantastic.
Yep.
Thank you, Dr. Bell. So we're going to do a bit of a general overview. Now, this is cash-based biologics, specifically below the knee. And although this is certainly geared towards podiatrists, we already know that we've got some integrated chiros, we've got some orthopedic surgeons, we have pain doctors, we have nurse practitioners, we have PAs. We have all sorts of providers on this call because all of you are seeing these patients. Why? Well, pickleball, number one, right? Number two, diabetes. And I'll explain. If we look at, the population in general, we have a population that is generally getting more sick, especially with this COVID that happened between 2000 and still continues to happen, right? We have more participants in more aggressive sports at older ages, and we have more cumulative trauma in patients that have more chronic disease. And the majority of that trauma happens in the lower extremity because we all have to walk to get around. We're not floating from one place to the other. So when these patients walk in the door and they're seeing podiatric surgeons and orthopedic surgeons and pain doctors, and they're seeing their primary care and their family practice doctor, and they have pathology, whether that pathology is, an osteoarthritis, meaning a cartilage-based defect in a joint, whether it's a soft tissue injury, whether it's, an autoimmune paradigm, whether it's a neurologic paradigm, where is almost every provider starting their intervention? Now, we're past rest ice elevation. We're past prescriptions, right? You're surgeons. So we're at the point of intervention. But where is 99% of that intervention taking place? It's taking place here. Now, what's happening to you in your practices? And I know because the same thing happened to me in pain. You've seen progressive reductions in reimbursement every year for the past 15 years. The surgeries that you were paid extremely well on a long time ago aren't even covered at this point in time. And if they are covered, right, you've got to get pre-approval for them. Standard injection procedures that used to pay very well, pay very poorly. Many of the things that should be covered by insurance aren't. And the amount of overhead that you accumulate on an annual basis goes up while your reimbursements go down. The standard doctor in private practice has a 15% increase in overhead year over year. And if you don't think that's true, ask any one of your front desk employees if they would leave you for 50 cents more an hour. 3 out of 5 of them will get up and walk out. And you know this because it's happened to you, right? Your best MA, your best nurse practitioner will leave you for pennies on the dollar. Doesn't matter how loyal they are, because most people who are working live right up to the limit of their income. And if they can get more income, they can live a little larger. And if you're the one that's in the way, they're going to leave you for someone who's going to give them more liberty so they can get that big slice of the American pie. How does this play out in practice? It plays out in practice because if you're a podiatric surgeon, orthopedic surgeon, pain doctor, medical doctor, DO, integrated physician, and a patient comes to you with pathology, if all you have to offer is cortisone, and we've been doing cortisone for 25, 30 years, if that's all you have to offer, where does the patient decide they're going to go? Because they don't want cortisone anymore. That's yesterday's news. They can get cortisone from anybody. So what do? Well, they're leaving your practices and they're going to the nurse practitioner. They're going to the PA. They're going to the integrated chiro. And what are they getting? They're getting alternative therapies, right? Maybe they're getting PRP, but by and large, what they're getting is biologics. Because these groups decided very early on that they needed to compete with your letters. They don't have the letters behind their name. They're not a surgeon. So how do they compete with your credentials? Some of you trained at Harvard, right? I didn't train at Harvard, but some of you did. So how does a nurse practitioner or a PA or an integrated chiro who's got MD oversight, how do they compete with your credentials? They change the game. And they offer something that you're not offering. They offer the potential of getting a better outcome using a different product. And because that biologic is expensive, even though they don't have the credentials behind their name, because they're offering it, they can charge more. I don't care if a Bentley is on a secondhand car lot or at the Bentley dealership, you're not getting a discount on that Bentley. And if you do get a discount on that Bentley, you're paying one way or another. I have a vintage Aston Martin. I got it at what I thought was an inexpensive price. I will tell you, you pay eventually because that car is in the shop all the time. And believe me, I am paying full ticket for that vehicle. What is my point? My point is the people with the credentials, the most credentialed, most experienced providers in medicine have been the slowest to adopt allogenic biologics. Now, there's a couple reasons for that, but what's the biggest reason? It isn't FDA issues. It's not. It really isn't. PRP is not FDA cleared, right? I'm sorry, PRP is not FDA approved. It's not approved to treat any disease process. Amniotic fluid wasn't indicated to treat any disease process, right? Most of us have prescribed gabapentin. Is gabapentin approved by the FDA to treat tarsal tunnel syndrome? No. But if you had to do a decompression of the tarsal tunnel and somebody got a neuropraxic deficit in persistent neuropathic pain of, say, the medial plantar branch to the tibial nerve, off-label, you would prescribe them gabapentin because it's FDA cleared to do that. In the standard practice, in the course of practicing medicine, because of your experience as surgeons, can you use something like gabapentin in a common sense manner that's consistent with your training and your education? Of course, you can practice medicine. So can you use an allogenic biologic that isn't quote unquote FDA approved to treat any disease process, but is certainly FDA cleared to supplement a cartilage-based defect? Yes, you can. So if that's the case, and most learned surgeons know that, what's the limitation? Dr. Martin, I don't want to feel like I'm selling. I don't want to sell. I don't want to feel like the guy down the street who's got banners and who's got, ads all over TV and the radio. I don't want to come off like a salesman. I'm a surgeon. So what we're here to do today is to eliminate the sale, explain how and why the allogenic biologic supersedes PRP and cortisone in every way, right? Walk through some of the histopathology in the biology, walk through the anatomy, and then because I have an expert in the field, because I have Dr. Bell on this call, walk through some clinical cases for the specific application of biologics. So this becomes immediately actionable in your practices, not 2 weeks from now, but tomorrow. So if you want to get some of those patients back, if you want to stand on your credentials in your Harvard training, and you want to start thumping those people who are taking all of your patients and charging them cash, you can get some of those cash paying patients back in your practice. And you can build the big, beautiful practice that you want, because as surgeons, you're probably like my father. My father's a head and neck cancer surgeon. He's 83 years old. My dad's writing checks just to practice in the office, seeing patients 6 half days a week. And he's stoked to actually pay money out of his retirement just to continue to see 2, 3, 4 patients a day, because it's all he ever wanted to be was a surgeon. And if he has to pay to be a surgeon, he'll do that. Let's dig into this a little bit. All right. I'm going to erase all of this. And by the way, this is being recorded. So if you want to review this, you're more than welcome to do so. But we're going to go through a case right out the gate. And we're going to talk through that case so that everyone understands. I received a call from an orthopedic surgeon 3 days ago. No, it's 4 days ago now. My apologies. Case is a 4-year-old patient with new onset polyarticular inflamed joints. Both knees and one ankle. Now, that 4-year-old in any office in the country having persistent inflammatory infusions in 2 knees and 1 ankle has maybe only a couple different diagnoses. And this is not an academic discussion about what that 4-year-old had, all right? Could have been Lyme, could be oligoarthropathy, could be juvenile rheumatoid, right? We don't know because we don't have all the tests back. So I'm not going to presume. But what I can say is that orthopedic surgeon did something so out of the box that I'm talking about it today to all of you. Because what would most surgeons have done? They would have given that 4-year-old cortisone, almost without question. And if that 4-year-old got cortisone once and it helped, and they got a recurrence, well, then they'd have gotten more cortisone. And then maybe they were referred to a specialist, and that specialist saw them for the first time in a different area of California, because this patient was in California. And what is that surgeon going to do? Maybe give them cortisone. And then maybe they go see a specialist because he does end up getting diagnosed with juvenile rheumatoid arthritis. And maybe he's got more than 2 flared joints. He's got 3. What do they give him? Yeah, they give him a Medrol dose pack at the age of 4.5 or 5, right? So more cortisone. Now, 6, 7, 8, 9, 10. What have we done to this 4-year-old boy? What have we done to his growth plates? By the way, this little boy is Latino, and mom and dad are both diabetic. And we're ramming this little boy with steroids. What is this little boy very likely to develop? Notwithstanding short stature, but almost absolutely going to get insulin resistance and or diabetes. So now I have a patient at 11 or 12 with premature closure of growth plates because of all the steroid, with an autoimmune disease because maybe it is rheumatoid arthritis, who now has diabetes. What's the life expectancy for this child with rheumatoid arthritis, with juvenile diabetes, having been giving tons of steroids, and now has probably steroid tolerant or even steroid resistant inflammatory arthropathy? And now has to go on DMARDs before they hit 13 years of age. We know the DMARDs are going to destroy the kidneys, the joints, and everything else. What's this child's quality of life going to be? It's going to be terrible. What did that orthopedic surgeon do? It floored me. He used an extremely complicated mix of biologics, and under experimental use, combined a Wharton's jelly product plus an exosome product. Now, many of you don't know what these things are. Most of you do. So we're going to discuss this in detail next. This patient at 4 years of age got Wharton's jelly mixed with an exosome product. And 2 days later, our symptoms resolved completely. Completely. Back playing. Had a slight flare after playing for 8 hours in the yard. Went home, rested. Following morning, no swelling in either knee or the ankle. Now, what would the expectation have been had they been given cortisone? 7 to 10 days, gradual progression and reduction of that inflammation. Cortisone is catabolic. We know it breaks down joints based on Radiology 2020. We know that serial application of cortisone accelerates degeneration of joints. So what did that orthopedic surgeon do? Potentially, probably save that child's life. And I don't say that lightly. Before the age of 13, with an autoimmune condition, early diabetes, tons of steroids, right? And Lord knows how many joints at that point in time. That's a terrible quality of life. Now, whether that patient dies or whether that patient lives, that is an awful quality of life, and all of us would agree that if that 4-year-old was our child, which path would we have taken? This path that the majority of us would do to somebody else because this is how we were taught. Let's give them cortisone. Or this path, which very few even know about. And I lecture to all day, every day, 6, 7 days a week. So we're going to explore this path so everyone understands. And I'm not going to talk for 2.5 hours like I did last time, but we're going to get into just some general anatomy so that we all understand what we're talking about. All right? I'm going to use a little bit different pen because that one's not coming out that well. We are all familiar with what a female looks like. We're all familiar with baby. All right? Umbilical cord. Umbilical cord itself is on average 28 centimeters long. And that umbilical cord is made of structural tissue. That structural tissue is called Wharton's jelly. Inside the umbilical cord, we have 3 vessels. And surrounding those vessels is a structural tissue, and that structural tissue has extracellular matrix, and it is Wharton's jelly. Now, Wharton's jelly histologically acts as a conduit. What do I mean by that? Well, that structural tissue is type 1 collagen, a little type 2, type 3, concentrated hyaluronic acid, and type 5, 7, 9 collagen. And that collagen is so robust that a 14-pound baby swings on that bungee cord for 9 and at times 10 months. And in fewer than 3% of cases worldwide annually, this cord gets kinked and the baby passes away. Fewer than 3% of cases worldwide. Because that collagen superstructure, which only exists in nature, in the umbilical cord of mammals, acts as such a strong conduit that it prevents this cord from kinking or knotting. Now, we're going to take another very simple scenario. As all of you are sitting there, you may be taking a snack. You may be reflecting on what you had for lunch or thinking about what you're about to have for dinner. Now, if we take a simple knee joint, I know we're talking about below the knee, but we're using this as a basic example. We take a simple knee joint, right? We have superstructures within the knee. We have the articular cartilage that covers the femoral head and the tibial plateau. And that is type 2 cartilage. We have lateral meniscus, medial meniscus. We have medial collateral ligament, lateral collateral ligament, ACL, PCL. All of those structures are type 1 and type 3 collagen. Now, How many of you have had type 2 collagen to eat today? And if you took type 2 collagen as a supplement, how many of you have had a water-soluble, bioavailable type 2 collagen? I would submit none of you have, because it's not common in our diet. And it doesn't exist in what we normally eat. Now, here's where it gets interesting. Does the body synthesize type 2 collagen? Well, the body has collagen in it, right? Because we know we have differentiated mesenchymal stem cells in the body, and those differentiated mesenchymal stem cells from blood, from bone, and from fat can generate collagen. What is the collagen subtype in blood, bone, and fat? It is only type 1 collagen. This presents a problem. Because if the articular cartilage is type 2 collagen, and the body only makes type 1 collagen, and standard degeneration of any joint involves 3 subtypes of degeneration. Degeneration of type 1 cartilage, type 2 cartilage, and type 3 cartilage. How the heck do we improve somebody? How do we keep them from a joint replacement? We could use PRP, but PRP only has type 1 collagen. Maybe we could do bone marrow and we could slam a needle right in the tibial, the tibia, and we can do an osteotomy of the tibia. Still only going to have type 1 collagen. What about fat? Maybe we can do a mini liposuction. And with that mini liposuction, harvest the mesenchymal stem cells from fat. Are we going to get type 2 collagen? We're not. So if I want to prevent regular, predictable degeneration of joints, because all of us are stuck here on this planet, and since we have gravity, we are exposed to progressive, inevitable, predictable degeneration of our joints and, just so happens, our intervertebral discs. Because the intervertebral disc that separates, say, L4 and L5, and if we look at it in cross-section, we have nucleus pulposus, we have annulus fibrosus. That nucleus pulposus is type 2 collagen. Isn't that interesting? So it's predictable that we're going to get degenerative disc disease and degenerative joint disease because type 2 collagen doesn't exist in our regular diet. The body doesn't synthesize it. The body doesn't make it. And there's no good source for it. Well, we've been using PRP, we've been using BMAC, and we've been using stromovascular fat for 10 years. Are any insurances paying for that? Not really. Why? Because the literature is soft. The literature is really soft. Now, of the literature on PRP or BMAC or stromovascular fat, that literature that demonstrates that PRP can actually create type 2 and type 3 cartilage. How is that literature created? That literature is created because they culture PRP in something called stromovascular fat. I'm sorry. Fetal bovine serum. Now you may ask, what is fetal bovine serum? Sounds like we're getting in the weeds, Scott. I thought this was going to be a general overview. We'll link some articles. But fetal bovine serum comes from fetal cows. And fetal bovine serum is very concentrated with collagenic growth factors, type 1, type 2, and type 3. So if I take blood and I culture it in growth factors that's type 1, type 2, and type 3, and then I plate that on a petri dish, and then I nourish that petri dish, and then I take cells off that petri dish and then inject them into an ankle joint. Am I going to get type 2 collagen? You betcha. What if I don't culture that blood in fetal bovine serum. Am I going to get type 2 collagen? No, I am not. Why are nurse practitioners, PAs, integrated chiros using allogenic biologics like Wharton's jelly? Because they don't have to use fetal bovine serum, notwithstanding the fact you can't buy it. It's research only. And Wharton's jelly has type 1 collagen, a little type 2, and type 3 collagen. It also has lots of HA. Now, to all of you podiatrists, this is going to be interesting because a lot of you have used amniotic fluid. Now, why did you use amniotic fluid? Well, you used amniotic fluid because amniotic fluid had an anti-inflammatory property. What was the anti-inflammatory property in your amniotic fluid? It was HA. The primary ingredient in amniotic fluid is hyaluronic acid. That's great. Does amniotic fluid have all the collagen building blocks that Wharton's jelly does? Nope. It doesn't, right? How concentrated is the hyaluronic acid in Wharton's jelly compared to amniotic fluid? Oh, just 100 times more concentrated. 100 times more concentrated. You're getting pretty darn good results with amniotic fluid until most of you stopped using it. You may have gotten okay results with PRP, but it hurts. It causes predictable swelling because it causes a pro-inflammatory response. But why are these nurse practitioners, why are these integrated chiros, why are they getting such great results with stem cells? Are they using stem cells? They're not. They're using Wharton's jelly. And why are they getting great results? Well, because they have 100 times more potent hyaluronic acid. And for those areas that they're applying that biologic that have complicated trifold cartilage-based defects, type 1, type 3, and type 2, they're using a comprehensive biologic so that when the body goes through the process of healing itself at a cellular level, the body goes through comprehensive collagenous differentiation, and the body makes type 1, type 2, and type 3 cartilage. Let me show you, and then we'll get into some cases. So, we're going to erase all this, and we're going to start our more practical part of this lecture. Now, we're going to look at a knee because I draw those better than I draw subtalar joints. But the pathology is similar. If I have a knee joint and I have a patient that has a lateral meniscal tear and they have a tear of, medial meniscal tear plus a medial collateral ligament injury, right? Say I want to apply a biologic to that knee. What happens? Do stem cells just magically make the patient better? Do stem cells just whisk away the disease? Well, people that are selling stem cells in, Mexico and Costa Rica and Panama would love you to think so, because they want your patients to write checks for $20,000 or $40,000. So they go there and they get stem cells, and without a whole lot of explaining, but a whole lot of pomp and show, maybe the patients get better, maybe they don't, but they got a great experience out of it, right? I'm not going to explain a lot about stem cells because patients are going there hoping the stem cells are going to cure them. Wharton's jelly has differentiated mesenchymal stem cells in it. Those differentiated mesenchymal stem cells actually don't do the heavy lifting because they have glycosaminoglycans. They have type 1 collagen. They have 2 type collagen. They have type 3 collagen. They have HA, right? They have proteoglycans. They have cytokines. But mostly what the MSC does is it acts like a contractor. And it tells cells what to do. How does it do that? Well, right before the MSC dies, it releases its most valuable payload, which is the exosome. And exosomes are little packets of information, and those little packets of information induce microRNA by way of an M2 macrophage pathway. This is all in the literature. We can supply all of this for you. What do M2 macrophages do? Well, M2 macrophages upregulate IL-10. They upregulate ARG1. And they downregulate IL-1 beta. Now, for all you folks that love literature, this is really sexy. And it took me probably 5 years of digging before I found this. This is a potent anti-inflammatory response. Very potent. That exosomes derived from Wharton's jelly can potently downregulate inflammation. Okay, what happens when we use PRP? PRP has a pro-inflammatory response, meaning the MSCs stimulate the release of exosomes, and they also stimulate microRNA, but the microRNA stimulates a M1 macrophage. Now, what does an M1 macrophage do? Well, that M1 macrophage upregulates IL-1 beta, upregulates TNF alpha, upregulates IL-6. What does that do? That is going to cause tremendous inflammation. This is why all of your patients who you've done PRP on end up, number one, having pain because it's pro-inflammatory. Number two, end up with a persistent diffusion. And if you've ever used amniotic fluid or you've used Wharton's jelly, they didn't get an effusion because the exosome component in the mesenchymal stem cell downregulates inflammation with umbilical cord derived products. Our body's MSCs from blood, from bone, from fat upregulate inflammation. Now here's where it gets exciting. Our 4-year-old boy, had we given that 4-year-old PRP, what would have happened? That 4-year-old has an autoimmune issue. Is his body able to efficiently downregulate inflammation? It's not. So if his body's not able to efficiently downregulate inflammation, and I give him something that's going to cause a bunch of inflammation, what's going to happen? He's going to have a persistent diffusion. Now at 4, not being all that ill, maybe his body will eventually quell that effusion. But what if he's 70? And what if he's been a rheumatoid patient for 50 years? What if he got COVID? What if he had not 1 COVID vaccine, but 2? What if he got 3 COVID boosters and has chronic Lyme? Does he have the humoral response to be able to downregulate inflammation? He doesn't. And so if you give PRP to a 70-year-old and they develop a persistent diffusion and they just happen to be diabetic, what's a 4-5-day-old effusion in a diabetic with autoimmune disease and impaired humoral response? Well, it's a persistent diffusion if you're lucky. If you're unlucky, it's a septic joint. And you won't know unless you see the patient and stick a needle in it and drain. And you're praying, because I've been in this situation, that it doesn't come out purulent. Because if it does, you've got a problem on your hands. Let's go back to the application of biologics. What happens at a cellular level? So I apply a biologic. Say I apply Wharton's jelly, and I put that in a knee joint or the subtalar joint of the ankle. What happens? Does magic happen, right? Do I pull out my Harry Potter wand and say Wingardium Leviosa? And do I just elevate their health? No, right? That's what you see in advertisements. That doesn't happen. So what does happen? What does happen is when I put Wharton's jelly here, we don't get a tremendous inflammatory response, but we get a bit. And what happens is MSCs from the body, from blood, from bone, and from fat migrate to the area by way of something called chemotaxis. And when they get to the area, there's a paracrine effect, a signaling effect. And it's basically like guys at a bar, right? Encouraging their buddy to hit on the pretty girl down the bar, right? Or girls at a bar suggesting their girlfriend should go pick up on the cute guy at the end of the bar, right? Or the person at the bar suggesting they should pick up somebody else. I want to be politically correct. But by and large, there's an entourage effect. And so the body goes through something called collagenous differentiation. The body, at a cellular level, generates cartilage. And it generates cartilage based on the cartilage subtype most present. So if I put PRP in a knee joint, that PRP's cartilage-based subtype is type 1 collagen. And when the body's own MSCs migrate to the area and start the process of collagenic differentiation, and the body starts to heal itself at a cellular level. I'm not doing it. The body's healing itself at a cellular level. What's it going to make? It's going to make a lot of type 1 collagen. Well, we already know that that defect, that meniscus, is type 1 and type 3 cartilage. That injury to the medial collateral ligament is type 1 and type 3 cartilage. And if there was enough trauma to injure the meniscus and the medial collateral ligament, we know for a fact that there was some trauma to the articular cartilage. And that's type 2 cartilage. So if I put PRP in, and even if the body quells that inflammation, is that repair going to be durable? Is it going to last? It's not. Because my body's going through unimodal collagenic differentiation. Now, what if I'd used Wharton's jelly? And Wharton's jelly's got type 1, type 2, and type 3 collagen-based growth factors. Well, then you don't get collagenic differentiation. You get my favorite, comprehensive. Collagenic differentiation, right? Cubed, because you're getting the body making its own type 1, type 2, and type 3 cartilage. And because we don't get type 2 in our diet, it's not bioavailable, and our body doesn't synthesize it. Is this a more durable repair? Will it last longer? Will you get better results? Absolutely. This, in a nutshell, is biologics in less than 45 minutes. Why do we use exosomes? Why did that orthopedic surgeon combine experimental use, right? Not treating, under experimental use. Why did he combine exosomes and Wharton's jelly? Well, that patient had a reactive effusion in 3 joints, and he needed to potently down-regulate inflammation, but he also wanted to put in cartilage-based building blocks because he knew that that inflammation is going to break down the joint. So he combined a Wharton's jelly product with a lyophilized exosome from Platinum Biologics under experimental use and got a fabulous clinical outcome. And at the end of the day, that's what we're looking for. We're looking for fabulous clinical outcomes. Why are we looking for fabulous clinical outcomes? Because no matter how much you're spending on advertising, one good patient outcome is going to refer you many more clients. Because one bad patient outcome can destroy your whole practice. Now, Dr. Bell, has been using these biologics for almost a year now, and he's gotten much more prolific, and he's really, really granular with how he applies these biologics. Dr. Bell, why don't we put a case up on the board? What would you like to talk about first? And I'll draw it out, and can you walk us through the details?
Sure. I'll start with a kind of a category, then give you a specific.
Let's do it.
Okay. So I think what's most exciting for us as podiatrists are the use cases. Our part of the anatomy is just so welcoming to what biologics can offer. And I make a strong argument these days as I've become more and more of a user and I've become more and more informed in the last year or more, that is actually a higher standard of care in comparison to much of what we historically used to treat conditions that walk through our doors every day. So we are definitely in a very unique situation. So I'll start with soft tissue. The foot and ankle, you could argue, is the first or last line of defense for support and structure. So the very, very first thing Dr. Martin discussed was the anatomy of the umbilical cord and how fascinating, nature and God is able to allow for things to work. So structure and support. We have 2 feet. They have to support our whole body, and they have to go through the biomechanics of walking, standing, or running. So what do we see all day long in this group of soft tissue pathology or soft tissue conditions that we treat as podiatrists? I'll name the structures. You all see them, I would assume, all day, every day. The plantar fascia, the Achilles tendon, the peroneal tendon, and the posterior tibial tendon. In my practice, that could be 7, 8, 9, 10 patients a day with one of those parts of the anatomy that is either newly inflamed or chronically inflamed. And sometimes that will dictate my approach. In our world, the anatomy being so far from the core of the body, being so distal, we have relatively avascular structures that we have to deal with. So the inherent healing process of any of the aforementioned structures, those tendinous tissues, is not easy. It's not easy for the body to make a repair because there's relatively limited arterial flow. So right off the bat, because of relative avascular tissue, because of high use tissue, and finally, because people don't simply sit on the couch all day when their foot hurts, we see patients all day long with these chronic conditions. And therefore, the traditional approaches, steroids and NSAIDs and ice, they often don't work, or we go to them too long. And the wonderful thing now is that we have a much better go-to. We have a go-to that shouldn't require the 3rd or 4th steroid shot in 10 weeks. We have a go-to that should not require the 10th week of Advil, Motrin, Aleve, or any prescription NSAID. That's not a high quality or high standard of care. We should be leaving that approach, okay? We should not be hanging our hat on constant traditional anti-inflammatory mechanisms. We know steroids are catabolic. We know NSAIDs have all sorts of downsides to them. GI effects, impact on our blood pressure. A week of an NSAID, no problem. But you have a patient on 10 weeks of NSAIDs, you can have a problem. And if you're not offering something different, something that's now available, to me, we're not offering the highest standard of care. So it's got to be, number one, standard of care should be high. And biologics do offer that. And then you have the benefit of high use case, and you have the benefit of safety. So let's just say in this case, I saw a patient recently, I'll say Achilles tendinopathy. It was one of my more interesting cases in recent history. Pretty big guy, works at Costco. Relatively young, probably late 30s. What's the first body part that's going to be impacted by a 35-year-old guy who weighs 200 pounds and stands all day? It's probably not his back. It's probably not his hip. It's probably not his knee. But his plantar fascia or his Achilles tendon all day long. So we see Achilles tendonitis, plantar fasciitis, as 2 examples again, all day long. Well, this guy, like a lot of hardworking young men and women, he kind of plowed through for months. And he had some pain in the back of his heel. And some days he'd ice it, and some days he would take Advil, and he would kind of get through. And then, like our typical patients, he wasn't getting through as well, and the ice was no longer helping as well. And he finally decided to go to his family doctor. And all his family doctor did was prescribe him prescription strength NSAIDs. I think it was diclofenac. He's on diclofenac for 6 more weeks. After resting and icing on his own, he finally gets referred to me. On exam, he has a palpable tendinopathy at his distal Achilles. I know that that's not new inflammation. He's beyond the inflammatory process. And I think for us, that is critical to explain to our patients. In many cases, you are beyond just the inflammatory process. There is pathology in the tissue. And I go out of my way to explain that. That's why Advil is not working. That's why ice is not working. You don't just have a little bit of inflammation. You have pathology. You have chronic inflammation, and that changes the integrity of the tissue. And there are things that you can do, of course, that we know that help change that integrity. Well, the most obvious is for the palpable Achilles tendinopathy, and this was large. This maybe not the size of a golf ball, but a large marble. And maybe historically, I would have sent a PT maybe 3 times a week and ultrasound and stimulation. It may break that tissue up, probably doesn't. He probably goes to therapy an hour, hour and a half, 2-3 times a week. And after 2 or 3 weeks, he kind of throws his hands in the air, he quits. Those types of patients come back to me or some time ago would come back to me and say, Doc, it's just not working, or I can't get there all the time. I work too often. What else can you do? And in those cases, traditionally, what else I could do is I could go in there, debride the Achilles, patch it with a xenograft, immobilize him for 4 to 6 weeks, and go through that typical recovery. And he's out of work for 12 weeks. Well, now I go to a biologic in this kind of case. And I apply a biologic. And for all the reasons that you all just heard from Dr. Martin, the mechanics behind how differentiated mesenchymal stem cells work, the exosome response, the types of collagen that then proliferate, they can help supplement that pathologic body part, that pathologic Achilles tendon, into a more healthy structure with better strength, better elasticity or flexibility, and restore the integrity of the tissue. And in this particular case, I believe it was 2 applications. After the first, I saw him about 4 to 6 weeks later. It was 2/3 smaller. I did 1 more, maybe 4 to 6 weeks later, completely asymptomatic, really not even palpable anymore. So something that was once almost the size of a golf ball in the distal Achilles, with no cam walker, pneumatic walkers, and an aggravated hip or back, walking around in a big old boot, and a guy who's 205 pounds, with just a little bit of rest, a slightly decreased work demand. I put him into it's kind of like a part-time work capacity for the first few weeks. He was 100% with very little time missed from work and with very little change in his lifestyle. And I'm seeing these types of examples all day long. The Achilles is just a more recent one, but we can apply it to all the tendon pathologies that we see.
So we're going to grab another case in just a second, Dr. Bell, but I want to jump off on this really quick. When Dr. Bell talked about using a xenograft, all of you are already using cartilage-based building blocks. You know it as a xenograft. You know it as a skin substitute. You're using cartilage-based growth factors, umbilical cord tissue, or placental tissues that are dehydrated because of the extracellular matrix, because of the cartilage-based building blocks. You might be using it to wrap a tendon. You might be using it as a xenograft. You might be using it as a skin sub to close a wound. You're already using them. You're just not using them this way and in this manner. Now, before we get into more cases, the reason you're here is because we talk about cash-based biologics. And what we talked about more is how this dramatically improves your practice. So we're going to go through this very same case, all right? Now, I'm not even going to talk about trigger points because that's really what you're billing when you do that. We're going to assume that we injected the ankle, all right? So let's just do some math, all right? We did an ankle injection. We bill for a 20610. Medicare pays a standard $59 and I think 95 cents for that 20610. Most of you are not getting paid for the ultrasound component. If you do, it's bundled and you still only get $59.95. Now you have on that $59 and we have to take a couple subtractions, right? we have to take out overhead. What's overhead in a podiatric office? Overhead, 65%. What else do we have to take out? Well, when we did that injection, what do we use? We used cortisone, probably Depomedrol. Depomedrol is expensive, right? Depomedrol is somewhere on the order of, $7, upwards of $15 per dose. Tell me the last time any of you have had a J code reimbursed. Never. J codes haven't reimbursed for 10 years. So you're out of pocket for that as well, right? Now, we're not even going to talk about if they hadn't met their deductible in the first 3 months of the year, right? Because you're not getting paid this either. You're not getting paid anything because they haven't met their deductible. Okay, so what is our net on this procedure if we just used cortisone, right? If we just use cortisone, and we're assuming this is all of our overhead, usually this does not include merchant fees. Usually this doesn't include the 7 to 10% for billing because most of us leave that out. This definitely doesn't include your malpractice because that's in addition to your office overhead, which is usually rent and supplies and employees. That doesn't include your malpractice. So what is this number really? It's more like 75%, sometimes 80%. So what is your net using cortisone on an ankle injection? It's usually between $5 and $7. You can't buy anything but maybe a Wendy's Biggie bag, right, for $5. And that's maybe if you're in Texas. Because if you're in Southern California, it ain't $5. The Biggie bag's like $5.99 or $6.99, right? But I mean, $7, that's worth your time. So let's look at a different paradigm. Say we still did our 20610. Say we billed Medicare, right? But we decided to use a biologic. Say we decided to use Wharton's jelly, right? And that Wharton's jelly cost us $150. Now, remember, what's the number one reason most surgeons are not using biologics? They don't want to sell. Dr. Martin, I don't want to come off like a salesman. I don't look like that slimy guy down the street. Okay, so don't sell. I'm not saying you're going to charge them $7,000, $10,000. What I'm saying is because biologics are not on the fee schedule for Medicare, you can bill the patient for the biologic. Does Medicare pay for hyaluronic acid? No, it doesn't. So you cut a script for the hyaluronic acid, they go to the pharmacy, and they pay $300 to $400 per syringe as a copay, because that stuff's like $1,500 or $1,800 a syringe. So they're already paying for hyaluronic acid. So would you rather have your patient pay the pharmacy or pay you? So let's just work on that. Let's work on that $400 paradigm. Patients used to paying a copay of $400. Instead of paying it to the pharmacy, maybe they pay you. So the Wharton's jelly's $150. The patient only pays for the biologic and pays $400. What is your net? Your net for the biologic is what? This isn't hard math. It's $250, right? Now, what if you're seeing 10 patients a week and they're only paying $400 for the biologic? Well, now our net per week is $2,500 a week. Per month is $10,000. Per year is $120,000. Okay. This is kind of exciting. I do 20 injections a week with cortisone. Is it reasonable to believe that all 20 injections a week are going to choose to pay $400? No. But that's okay. Maybe half of them do. What does $10,000 net a month do for you? that pays for an exceptionally good nurse practitioner. So you can increase your clinic time. You can see more patients, potentially do more biologics. What happens if I change this $400 and I charge $600, right? What happens to this number? It goes up exceedingly. Now, what is the going rate in the US for PRP? It's $500 to $1,500. Who's doing most of the PRP in the country? That's $500 to $1,500. There's practitioners, PAs, integrated chiros. They're charging more than this. And you have bigger letters behind your name. Now, can you charge more? Sure you can. Can you do a more mature application like the orthopedic surgeon did, combining exosomes in Wharton's jelly? Sure you can. Experimental use, please. But how do I suggest that people in the door? You know what I like most about this model, which I call the hyaluronic acid model? What I like most about this model is house cash. This is my favorite thing in the world to tell a doctor. Hey, look, you've been using a biologic that's all of $150. How much house cash are you on now that's been 2 months? Doc, I've made like $24,000 cash in the last month. Do you know how much overhead there is on cash? None. There's zero overhead on cash, right? Now, I mean, maybe there's merchant processing fees if they give you a credit card, right? But a lot of people pay cash. They write a check. Do you have to pay a biller 7% to 10% cash? No. Do you have to wait 6 weeks for Medicare for cash? No. How much longer do your lights have to stay on? How many more employees do you have to hire for a patient to hand you $400 in cash? None, because you're already paying them. The overhead for cash is zero. What can you do if you're on $22,000, $24,000 in cash? Well, maybe you can start to get into more esoteric areas using biologics, more complicated applications of biologics, more nuanced experimental use cases of biologics. And even though those biologics cost more, you're going to be charging much more. And because you're charging much more, patients are going to pay you much more. Integrated chiros and the FPs and the nurse practitioners, why are they charging $6,000, $7,000, $8,000 for biologics? It's because they started making house cash 5, 7, 10 years ago. They started using biologics that were $150 and they built up a war chest of cash, dipping a toe. And then in the course of seeing more where they were just charging for the biologic, they came across much more pathology, a more complicated disease process. And patients had failed conservative measures. And they said, well, look, a biologic that's, this price isn't as a more expensive biologic. I can't charge you $400. The biologic cost me $1,000. So I'm gonna have to charge you $2,500, $3,000. Okay, I'll pay that because I don't want surgery, because I can't have surgery, because I'm the sole breadwinner for my family. And if I can't work, the mortgage doesn't get paid. Food doesn't go on the table. My kids can't go to the school that they love. I have to move in with my folks at the age of 45 because I can't afford to live the way I'm living. So sure, here's my cash. Please help me because I can't afford the $7,500 or the $15,000 for my insurance that's my deductible just to have the surgery. I don't have 15 grand, but I've got 5 or 6. What can we do? What can we work out, doc, for like $5,000? Because I've heard that, it usually takes more than one application to get better. Do you think we can figure something out, Doc, where you give me something more robust, but I get maybe 2 applications so that I can stay working? Because I can probably afford $5,000. Maybe I put it on a payment plan. Maybe I take money from here or there. But I absolutely can't afford my $15,000 deductible that I'm absolutely going to get if I have surgery. And I can't afford the time off where I get paid nothing. This is how the integrated chiros and the nurse practitioners and the naturopaths are charging $4,000, $5,000, $7,000, $10,000. They built their business on house cash, started small, built slowly, built competence, built familiarity, developed an understanding for how these biologics worked. And then when cases came along that were more complex because they were comfortable using an elementary biologic, started to use more complex blends of biologics to achieve better results in more significant pathology. Dr. Bell, let's get into another case. What do you have for us? Something a little more complicated, please.
Okay, so maybe what's most exciting for me. Again, whoever in the audience, I'm sure a lot of podiatrists, there's no way you're all not seeing a lot of diabetics. And the percentage of diabetics that suffer from the disease neuropathy, I would argue there's data on it. It's close to 50%. What have we done historically for the symptom of neuropathy, neuropraxia, or sensory nerve damage? Nothing. Nothing to treat the nerve damage. We treat the pain. We've treated it. The family physician has treated it. People like Dr. Martin in his field, pain management, have treated it. All with what? Gabapentin and Lyrica. We all know that gabapentin and Lyrica do not help reduce or work on the actual degenerative changes in the nerve tissue. So we just mask the pain. We're also putting these patients who have a lot of comorbidities and are probably taking a lot of other medicines on a medication that has side effects. We have diabetics, of course. We always have to worry about their kidneys. Patient on 800 milligrams of gabapentin for 15 years. Well, that's not a very kidney-friendly situation. So we now have another option. We have an option to treat a disease state that's never been treated before. So for me, super, super exciting. So my patient has neuropraxia. When they have the paresthesias, when they have the burning, the tingling, numbness, when they're not end stage, biologics can really have an impact on the structure of the outer layer of the nerve tissue. Redefine that structural collapse that causes the paresthesias, and the paresthesias become less significant. I've seen it in countless patients over the past year or so. So let's take a patient. Again, for me, for most of us, for me, more than a few a week, but let's just say a few a week, 3 or 4 a week, and the average office would be fair. This has become my standard. In an initial visit, I always feel obliged to at least discuss it, explain to them what neuropraxia is, talk to them about how the overload of glucose in tissue that is not dependent on insulin. So we know the kidney, the blood vessels, the nerve tissue does not depend on insulin to pull the glucose into the cell. So you have all this extra glucose because they're diabetic, and it just finds its way into the cell. It goes through a pathway that the end result is sorbitol, which is essentially an alcohol that disintegrates the outer wall of the epineurium, the outer layer of the connective tissue surrounding our nerves, and that causes paresthesia. Well, the biologics, they can help reverse that. They can help rebuild structure by all the mechanisms that Dr. Martin had mentioned. So I can actually now offer something that is attacking the actual condition and not massing it in the head. So the typical patient, let's say, most often, if you catch them relatively early, a year, 2 years into their neuropathic-like symptoms, they're symptomatic on the plantar aspect of the foot, mostly distal plantar. So it's branches of the posterior tibial nerve that are impacted. And again, I go back to our field. We're such a great use case because the more distal or the further away from the core of the body, a lot of times the impacts of these disease states are greater. So again, you don't see as much neuropathy, say, in the arms. You don't see neuropathy in the thigh, but you see it in the foot. Those small sensory nerves in the foot are very susceptible. They're vulnerable based on everything I just mentioned. So what I do now is I go through a protocol where I apply, say, a Wharton's jelly to the tarsal tunnel. And I think Dr. Martin and I spoke about it once on a telephone call. We talked about, or we looked at it like watering a plant. You don't dig the dirt out and pour the water in the bottom of the potted plant. You pour the water on top of the soil, and then it infiltrates throughout all the branches or the roots, and eventually gets to the most bottom roots that are helping really feed the flower, feed the plant. So what I do is I look at like the same concept, and I apply the biologic just proximal to the tarsal tunnel. I think for us, our anatomy is pretty straightforward. We all know where the posterior tibial nerve is. I go a couple centimeters proximal to the ankle, and I apply my Wharton's jelly there. And when the symptoms are just plantar, which is often the case, again, it's a 6 to 8 week process that I wait. I have them return. We discuss their symptoms. Oftentimes, I'll do metrics. I'll do epidermal nerve density tests, which is a great way to get a good metric on sensory nerve damage. That test I'll repeat maybe 6 months afterwards, but their symptoms are often improving within 6 to 8 weeks. I tell my patients it's usually a process. Like Dr. Martin discussed, we sometimes get a little bit sexier with it and do different versions of Platinum's products. But to keep it real simple for this little example, I'll say I'll apply a second or a third round of my Wharton's jelly. So 6 weeks, 12 weeks, 18 weeks. And I have dozens, probably more than dozens at this point, of patients with substantial improvement in their paresthesias. Thrilled patients. I'm either getting them off gabapentin, I'm lowering their doses of gabapentin, or they're never starting gabapentin if they get to me first. So if they've been a current patient of mine for 15 years and I've been the one prescribing gabapentin, I'm passionate about telling them and informing them about the biologics. I tell them we have a new plan to get them off this medicine or at least reduce the dose. Very exciting for me. But if I catch them early and I'm the first doc to treat the neuropathy, and in my demographic, I get those referrals all the time from the family docs. They don't even want to touch them. I start with this higher standard of care. A biologic is a higher standard of care than dumping 800 milligrams of gabapentin into somebody once or twice a day for the remainder of their life. So again, I go back to standard of care. It is below, in my opinion, the standard of care to dump somebody on gabapentin or Lyrica when we have this option. It has to be at least discussed to our patients. So this use case is my favorite.
So let's get into a little bit of the goodies, all right? Most people are aware that every peripheral nerve that is myelinated, right, has 3 layers to the nerve. You've got the endoneurium, the perineurium, and the epineurium. Most people don't know that the epineurium is actually dense irregular tissue. It's type 1 and it's type 3 collagen. Well, we're familiar with myelination, and that myelination is bundled up in heaps on the nerve, and information travels down the nerve by saltatory conduction, meaning that information is from internode to internode. What I tell people is that conduction down a nerve through axoplasmic flow using the phenomenon of saltatory conduction, it'd be like driving from Las Vegas to LA and jumping every 8 cars. That would be fabulous because I go to Orange County a lot because I married a gorgeous little girl from Southern California and she likes to go back. Well, when you have a neuropraxic deficit, you have a deficit of not just the myelin, but also the epineurium. Well, does myelin attach to the axon of the nerve? It actually doesn't. Myelin only attaches to scaffold. It literally needs something to climb on, something to adhere to. And without something to adhere to, it doesn't start to wrap a nerve. And without remyelination of the nerve, you don't get neural sprouting. You don't get new dendritic formation, and new neural recovery. Fascinating, right? But essential and missed in most applications is the fact that that neuropraxic deficit, maybe it's the top of the nerve, maybe it's the bottom of the foot, is in pathology of dense irregular tissue. So can we use a biologic to treat neuropathy? No, we cannot, because we can't use any biologic, PRP or otherwise, to diagnose, treat, cure, prevent disease. But can we use a biologic to supplement a cartilage-based defect, to put collagen-based building blocks in an area where we are deficient, where we have missing, damaged, deranged, deteriorated cartilage? Yes, we can do that. Now, what if we want to do something more esoteric? What if we want, from an experimental use, to address somebody who had an inflammatory neuropraxic deficit? Could we apply an exosome product by IV route of administration, by nebulized route of administration, simply buying a $40 nebulizer off Amazon, reconstituting a product that's 50 billion exosomes, and inhaling it in through the mouth, out through the nose, to systemically down-regulate inflammation, to systemically increase ARG1, increase IL-10, decrease IL-1 beta? Sure, we could do that. Because almost all of you as podiatrists and many of you as pain doctors or chiropractors or orthopedic surgeons or nurse practitioners or naturopathic doctors understand that most neuropraxic deficits, as well as neuropathy in general, are the result of an inflammatory paradigm. This is what comes next. And I tell people this all the time, all right? If a patient is screaming at you over their copay, $5 copay, they want to report you to the medical board because you're making them pay their copay, right? $5. If they're screaming at you about their copay, are they going to hear any of the instructions that you gave them on how to take the prescription that you handed them? No, not at all. Well, the body works very similarly. If I've got a bunch of inflammation that's destroying the epineurium of these peripheral nerves, if I put in a very complex cartilage-based building block tissue with extracellular matrix and all the goodies, even if I put in a really expensive Wharton's jelly, $1,000 product, is the body going to go through collagenic differentiation? It's not. Because no different than the patient that's screaming at you about the copay, until you reduce the heat in the room, until you quell the inflammation in the conversation, they're never going to hear what you want them to do with the prescription you gave them. So if we can't handle inflammation in the body using something like an experimental application of exosomes, are we going to get robust collagenic differentiation and hopefully recovery of the nerve by way of collagenic differentiation in the epineurium of the nerve? We are unlikely to do that. So in a more complex application, if you feel that that neuropraxic deficit is inflammatory induced, you can apply experimental use in exosome first, IV route of administration, nebulized route of administration. And then a couple weeks later, as Dr. Bell stated, apply your Wharton's jelly just distal to the fibular head, just proximal to the tarsal tunnel, right? Some people like 0, 6, 12 weeks. I prefer a more abbreviated application, 0, 4, 10 weeks. Neither is right, neither is wrong, right? But that nuanced application, being more mature, may not be something you do right out the gate. Maybe you use just the simple Wharton's jelly right out the gate, get some good outcomes, right? And build that house of cash. And when the patient comes along that does have a very obvious inflammatory paradigm, and the result of that inflammatory paradigm is this neuropraxic deficit that, based on electrodiagnostic testing and monofilament testing, you can correlate with pathology of the perineal nerve with dysaesthetic, slowing conduction velocity across the fibular head, slowed conduction velocity across the tarsal tunnel, failed monofilament testing in the distribution of the superficial perineal nerve, failed monofilament testing in the distribution of the medial plantar, lateral plantar, calcaneal branch of the tibial nerve. Then could you apply a biologic and track outcomes at, say, 0, 3, and maybe 6 months? You betcha. We've got a large group that's in Missouri, and they're collecting conservatively 100, 200 patients using this protocol. Not using the nuanced protocol, the experimental application of exosomes prior to the application of a cartilage-based building block to a cartilage-based defect in the epineurium. But based on their early results, and they're looking to publish this data, and I think it's fabulous, with just this elementary application of a product that costs $150, they're seeing 43% improvement in nerve conduction velocity. They're seeing 42% improvement in monofilament testing, and that's correlating with a roughly 45% improvement in clinical symptoms in over 50% of their patients. Now, all of us have seen patients with neuropathy or neuropraxic conditions. I saw it for years. I still see it, right? And just as the wonderful Dr. Bella stated, how much good do we do hammering a 70-year-old patient with 2,700 milligrams of gabapentin, burying them under 150 milligrams of Lyrica 3 times a day, flipping a coin and hoping that giving them the tricyclic antidepressant doesn't make them woozy or so dehydrated that they fall and break a hip? Isn't this a more elegant application of the biologic? Much more elegant, right? Not only is it more elegant because it's cash-based biologics, and many of you are seeing tons of these patients in your office. Per application, if the biologic used right, used left, cost you $300, even if you just added that $250 in profit and charged them $550, what's everybody else in the country doing? What are they charging for neuropathy programs that have light therapy boots and proprioceptive retraining and physical therapy and, balancing of antagonistic muscle groups? They're charging $7,000 for these paradigms. And they're getting paid that all day long. They don't have the letters you have. They don't have the Harvard training. They're not surgeons. But people are writing huge checks for that, and they're not even using biologics, most of them. So are you really selling if you're adding $250 or $300 or $400 to the cost of the biologic when the market bears a price point of $500 to $1,500 for just PRP? And as we've described, this is far more efficacious and way less inflammatory than PRP. I think this sells itself. I think this is about as elegant and as easy as it gets. Now, we can dig into use cases for hours and hours and hours, right? But I think we've gone over the broad strokes. I think we've addressed a lot of the nuance with how you would charge for this, how you would just increase the price of the biologic $250, $300 over cost, start with an aggressively priced biologic so you could pass that aggressively priced intervention on to your patients, And as you build competence with these biologics and as you build a war chest, start to address some of these more nuanced applications. Before we kind of sign off here and take questions, Dr. Bell, is there anything else you want to address? I know you've really seen some just amazing cases, but you were recounting a patient that you'd seen that had just wonderful results. I'm a big storyteller, and since I'm delighted to share this presentation with Dr. Bell, Dr. Bell, would you tickle us with one of your fabulous stories and about one of your really significant outcomes using these biologics from Platinum Biologics that you wouldn't have otherwise gotten had you been more traditional in your approach?
Sure. I could probably think of a more egregious case, but I'll mention this because it was exciting. I can't mention his name. He's a professional fighter. He's a UFC fighter. So I won't say his name, but there was a significant Achilles tendon. I'll go back to the Achilles in a different sense, an acute injury, a rupture. So an Achilles tendon ruptures, it's a surgical situation, as we all know. Historically, any athlete, I don't care, NFL, NBA, whatever high level professional athlete, historically, until they're playing in those types of sports again, it's been always about 1 year. In recent history, maybe down to 10 months or so, with, like we spoke earlier, wrapping the tendon in a xenograft. But this UFC fighter, after the surgery, again, and about what you mentioned earlier, I did a little bit tighter, about 4 weeks out, 8 weeks out, and 12 weeks out, Wharton's jelly. He was training to fight 7 months from the day of surgery. There is no way, I've done this for 21 years. I have a nice connection to the Philadelphia Eagles. I treat a lot of high school and college athletes, and I have a bit of a connection to the UFC. There has never been a patient of mine, and I'd like to think I do a good job surgically, that has trained with that level, at that level of training, what they're required to do, what you can imagine a fighter needs to do, and throwing a kick, punches, the grappling. There's a lot of demand on the Achilles, and we don't want these guys re-injuring. It was mind-boggling to see this guy training to fight on the day, it was the anniversary from a month standpoint, 7 months out. It was not all me. It couldn't have been. It's never happens that way. I see 10, 11 months here and there for my Achilles ruptures, but I've never seen 7. And this was somewhat recent. So this was a really, really, for lack of a better word, this was a cool case.
I love it. So how do we start? Well, Dr. Martin, this is great. I'm about to fall asleep, or I'm ravenous and I'm going to go eat something. And, now you've got me looking for something that's got type 2 collagen in it, jerk, right? How do we start? All right. Well, you can start one of 2 ways. All right. Nano Jelly is a cryopreserved product, right? It's extremely affordable. Can be used for soft tissue paradigms, can be used for joint, can be used for neuropraxic paradigms, right? Not everyone wants a cryopreserved product. Some people are like, hey, Dr. Martin, you know what? I don't want to have a cryo freezer. And I do a lot of cases in the hospital, and I actually have my own surgery center. And you know what? If I bring in a cryopreserved product, they're going to look at me funny, right? And I would love to throw this into my arthrodesis. I would love to throw this in, when I'm doing an Achilles repair or I'm doing a ligamentous repair, especially in a diabetic, because I know they're going to heal poorly. And at that price point, at an aggressive price point, like, $150, gosh, that's cheap. I can just tuck that right in, and I can ask the patient to pay for the biologic, even though I'm doing surgery, and I can still charge them, say, $500 for the biologic, and I can make a solid $350 cash, which is probably more than my professional fee to do the surgery, depending on the surgery. What if I don't want cryopreserve? What if I do have a surgery center? What if they don't like cryopreserve? What if I just don't want a cryo freezer? Well, most of you don't know, but Platinum, because they're so out of the box, they've created 22 different products, listened to all of you that didn't want to use cryopreserve, that wanted something easy, something simple, something just walk in the door, ready to go, shoot from the hip. It's a brand new product. and it's called nano DPM, dehydrated particulate matrix. It is a lyophilized Wharton's jelly. Now, nano jelly is about 70 milligrams of Wharton's jelly. This is about 100 milligrams of Wharton's jelly. All right. I'm not going to discuss price because I'm not that guy. You can all talk to your reps or you can request pricing for this, but this is also extremely affordable. Very affordable, much cheaper than xenografts, much cheaper. Now, what can you do with that lyophilized product, right? Say you love PRP. Well, you can add it to PRP and you're not changing the volume. You're just adding much more potent growth factors. Can you add it to bone cement when you're doing an arthrodesis to try to enhance collagenic differentiation, both osseous and otherwise? You betcha. You can add it to a bone cement. Can you reconstitute it in normal saline and do all of this soft tissue and joint and neuropraxic application? Sure you can. Just reconstitute it in normal saline. Usually I like 3 cc's. If you want to sprinkle that into a surgical site to try to accelerate collagenic differentiation intraoperatively, can you put that in a surgical site? You bet. You got tons of normal saline when you're in surgery.
Dr. Martin, can I interrupt real quick?
Yeah, please.
Very brief. So every podiatrist out there, bunion surgery, dime a dozen. This wouldn't happen too often. Recently, I had a patient, she's a runner. If she doesn't run, she loses her mind. It probably is a stress release, okay? This is not uncommon in the world of runners. You're laughing because you know. I see this a lot. But she couldn't avoid her bunion surgery anymore. Been driving her bananas for years. It finally, she said, I'm done. Instinctively, she knew she wouldn't be able to run for quite a while. That's why she put it off for years. She finally has her bunion surgery, but during the consultation, I normally wouldn't even mention it for bunion surgery. Pretty straightforward. Let them go through the recovery. I probably don't even bring up a biologic. But in this case, when she's, and I know her well because she's been out of my office multiple times with years for her other issues that are related to running, I say to her, Jennifer, I said, if you're that anxious, she's saying, when can I run again? I said, what's run mean? What are you talking about? A half mile at 3 miles per hour? No, I'm talking about 4 miles at an average rate of 7 miles per hour. Okay, Jennifer, 4 months. That's the reality. It's going to take 4 months. She's can't take it. I said, okay, spend a little money. I'll do a perioperative or when I close you up, I'll apply some of this Wharton's jelly, explain to her what it is. It'll augment the process, blah, blah, blah. She was running in about 2.5 months. It probably spared her 6 weeks. For her, $800 for 6 weeks earlier to run was a home run. So I get those
all day long.
Yep.
All day long, right? So why are we using this? Well, it opens doors that this doesn't, especially intraoperative doors. And this is one of the reasons we created this. Because if you're a podiatrist, you're a surgeon. I'm a needle jockey, right? I did lots of spinal cord stimulation. I put batteries in people. That is not surgery, all right? That's nuanced needle jockey. You're surgeons. So Platinum wanted a product that met your specific requirements so you could walk into any surgery center. You could do anything you wanted with this biologic. You know, when I take a xenograph and I want to wrap, a tendon, I mean, I spend 40 minutes kind of, because as soon as I wet it, it turns into this like globule, and I got to like tease it apart and try to hook it around the tendon. And, I've actually cut the tendon and I've even like got into blood vessels, just trying to like figure out how to wrap the tendon. Spray it down. Spray it down, right?
Very true.
You want it to stay a little bit longer? Reconstitute it with hyaluronic acid, right? It's going nowhere. You want it to, be a bit more diffuse in that operative site? Add some normal saline. This is kind of where we're going to end at this point. I'm going to let Beeben jump in and kind of quarterback the rest and direct the rest that he would like. Certainly, if there's anything else you want me to address and go over, I can talk for another 2, 4, 5 hours. But I want to be respectful of people's time.
I think with that, guys, let's come to a little closing point here. If we do have the Q&A out. So before you guys run out, a couple things I want to notate here. If you're new, please understand that we do have what I know as the only peer-to-peer on demand, which means Dr. Bell and Dr. Martin both have calendars to do a one-on-one with you. How do I identify these patients in my clinic? How do I get started? How do I overcome this objection? These are totally open peer-to-peer calls that you can book at your leisure. So we'll have a follow-up email to everyone in this, and make sure that you get all of those assets. Make sure you get into the private Facebook group and everything else. We're also taking a poll next week for our next lecture, what topic we're going to be doing. But I think with that, Dr. Bell, anything else you want to say from the clinical standpoint of podiatrists, looking to use biologics? I think one of the things that I kind of, laugh about now that we have nano DPM on the board, podiatrists use wound care, and I obviously know the wound care space, and we know that's not going to last forever, right? So adding some cash opportunity is great. But the lyophilizing of Wharton's jelly, I remember how freaked out I was. I said, we can't even launch this product to everyone because our main customer is going to go, wait a second, if it's not cryopreserved, it's not going to have stem cells. And if it doesn't have stem cells, it's not going to work. And I remember thinking, man, the podiatrists aren't going to have this problem because they understand biologics from all these wound care grafts and all of the grafting you guys have been doing. And I think you guys actually see the bad part of this. I think you're the only person I got to meet very intimately that, on a Wednesday cut someone's leg off. So I think the consequences are real. I think that the opportunity is real. It's necessary. But anyways, I've learned a lot from you as a podiatrist. I just kind of like to have your closing statements on biologics, where podiatrists are at in the current marketplace of understanding biologics from a cash perspective.
Sure. So, I touched on it a little bit. We are unique in that our use cases are so vast. Again, we live in a world of chronic issues. I started off by saying that the foot's the first line of defense. You don't very often see a 30-year-old with back, hip, or knee problems if there's no structural deformities and if all things are being equal. But a 30-year-old nurse will often have stubborn plantar fasciitis or Achilles tendonitis. So we are seeing chronic pathology at all stages of life, but even early in life when there's really no underlying structural issues. It's just that the foot and ankle takes such a beating. And I say this often in my practice, if you have a bad shoulder, if there's maybe a rotator cuff issue, and this resonates with my patients, I say to them all the time, you don't have to throw a baseball with your son every day if your arm hurts. You don't have to lift weights. But if your feet hurt and you have plantar fasciitis, you're not going to stay home from work. You're not going to go and not food shop for your family. You're not going to live life. So you're going to keep using this body part. And when you continuously use a body part that's inflamed, you're going to change the integrity of the tissue. And that's why we as podiatrists, we treat a lot of conditions that are very stubborn. We don't very often have like a one and done case. It's multiple steroid shots traditionally. It's 6 weeks of PT, plantar fasciitis, Achilles tendonitis, the peroneal tendonitis, the posterior tibial tendonitis. So those 4 soft tissue structures are historically stubborn because we keep using them. And a biologic is just superior in its outcomes compared to most of what you use traditionally. So we as podiatrists have to look at that huge group of soft tissue pathology as this is a new avenue. This is the way we should be thinking. Not always visit one. I'm not saying that. But by visit 3 or 4, and the traditional stuff is failing, or even visit 1 when they tell you, and I do this, that doc, I should have been here 6 months ago. My heel's driving me crazy. I explain to them, and I tell my other doctors when I do peer-to-peers, they probably do not have plantar fasciitis anymore. They probably have plantar fasciosis. That's different. It's not just an inflamed soft tissue structure. The soft tissue structure is now, there's pathology. There's histopathology to it. And steroids don't really do anything in that regard. They're anti-inflammatories and they're catabolic. We have to be careful at that point. And we should offer something better if it's available. And when this differentiated mesenchymal stem cell goes off and it sends out these exosomes and the body, produces its own collagen to come in and do its thing. People love the word supplementation because we're in that world now in medicine where the body can do so much for itself with the proper hydration and vitamins and proper diet and so forth. So it resonates to my patients that the body can help itself if you give it a little bit of fuel. So between the soft tissue pathology I just mentioned and all those tendinous structures, the bone and joint disease that we treat all day long, for me, again, on a given day, ankle arthritis, subtalar joint arthritis, first metatarsophalangeal joint arthritis. If you catch those early, this is a great way to approach them. Again, all day long. The most exciting for me, as I mentioned earlier, the paresthesias, the neuropraxia. I can't stand masking an issue. And when you have an opportunity to really look at treating a problem as opposed to masking with a drug that has lots of side effects. And again, the family doctor, the pain management physician, and the podiatrist have been prescribing gabapentin and Lyrica for 3 decades. We don't have to anymore. And we really shouldn't, or we should at least discuss this. They deserve the right to know that there's a healthier option. And then I'll touch on last bit, and this is exciting too for me for a few reasons. I'll touch on wound care. Wounds, the most serious thing that we treat, arguably. I do a ton of limb salvage, and unfortunately, I've done many amputations. But I treat wounds. It's a big part of my practice. And one of the better mechanisms of treatment for wound care, and I feel strongly about it, are skin substitutes. They're pretty darn effective. The problem with skin substitutes is that you have to meet a significant amount of metrics to even start using them. And aside from that, if you don't really know what you're doing and your notes don't cross every T and dot every I, and you face an audit a year or 2 down the road, and it's one of Medicare's favorite topics to audit us on because it's a high ticket item, you're potentially in for a real problem. So as podiatrists, I see many are afraid to use skin substitutes. So this was maybe another alternative. We don't have to meet criteria. I can offer a biologic for a wound visit 1. I don't have to wait for 30 or 40 days and show that wound, it's getting worse. Now, can I prior authorize a skin sub and wait 10 more days to hear yes or no? And now can I start doing it and pray to God I don't get an audit in a year or 2? So it's actually, interestingly, it's a weapon we can use at our discretion at any time with no fear for even wound care. So I evolved probably from soft tissue, bone and joint, neuropraxia, and finally I started saying, why not? Aren't we obligated to offer our patients the highest level of care? Well, if I can't go to a skin sub for at least 30 days and wait till this wound's regressing, but I have a biologic that can do something that has some of the same properties to it, but I'm not beholden to anybody. It's my decision. So now I can offer patients immediate wound care at a higher level as well. So we have such great use cases. It's something that I hope our profession really starts to recognize and distinguish ourselves from many other physicians in that we're offering high quality of care with really no risk factors, high success rates, and just better options than so much of what we use traditionally. Between steroids, gabapentin and Lyrica, and waiting along for approval for skin subs, we now have these biologics as options for so much what we see that I would argue is better quality of care. And number one to me, it's great. The cash part's great, obviously. I mean, we're entitled to make money. In fact, when I teach, I operate a teaching hospital in my inpatient surgeries. And I don't teach the residents too much about medicine, frankly. They have 30 other attendings that teach them that. I teach them about business because these young docs, I actually feel bad for them. They're kind of wet behind the ears. They're a little utopian these days, the way they're educated. And they think it's all kumbaya and just help people, which should be the first thing. But when you come out of medical school and you start your residency and you're $350,000 in debt, you better damn well know how to create a good practice for yourself. And you should know that there are other options that can make you a heck of a lot more money because we do live in my opinion, we do live in a free market. And it's okay to charge for your services, for your expertise, for your knowledge, for all the efforts you put into studying your outcomes. And this is what I teach my residents. And I've taught them about this is an arena of medicine that you guys don't learn one thing about in medical school or in residency, but you're going to hear it from me all day long in the operating room. So it's just vast. The vast case usage is for podiatry is excellent. It really simplifies your practice. You get great outcomes and you do make a heck of a lot more money if you can really make it a big part of your practice. And there's no reason you can't because its use case is so broad. So obviously I'm passionate about it. I try not to speak too fast, but I love it.
Thanks, Dr. Bell. All right, everyone. With that, I want to let everyone know if you haven't used any of the Platinum products or the products being discussed tonight, you're more than available. We actually offer no-cost samples. We just ask that you have had a successful peer-to-peer and you have some relative idea what the hell you're going to do with the product. So as long as you've talked to either Dr. Martin or Dr. Bell, look, we'll send mass amounts of samples out so you can see it to believe it and it also falls underneath our outcome guarantee. So with that, everyone, we will conclude this meeting. We want to thank you all for your attendance. Gentlemen, doctors both, thank you so much for your time, your continued efforts, helping the patients you do, but helping so many of these doctors apply these awesome biologics. We appreciate the hell out of you guys. Have a wonderful night, everyone. Bye-bye.
Have a blessed night.